Emily Ross, and welcome to today's session. I see a lot of doctors and office managers, and as you all know, today's webinar is about MACRA, introducing of MIPS and APM. I will provide few information about SybridMD, then introduce the presenter who will start the session. The webinar is for an hour, and at the end of the webinar, there will be a session for question and answer. So SybridMD is a healthcare service provider which was founded in 2009. Our medical billing expert team, who works with providers nationwide, focuses on decreasing stress of the billing and helps to increase cash flow. We also have our management team who has more than 5 decades of experience in managing the revenue cycle of practices from different specialties. So that was about Sybrid. Now let me go ahead and introduce you to our presenter. His name is Mr. Usman Amjad. Mr. Amjad is a certified MACRA, MIPS and APM professional who has over 10 years experience in healthcare industry. Mr. Usman, you want to take over?
Good afternoon, everyone. Thank you, Emily.
You're welcome.
So today's webinar is first of our webinar series in regards to MACRA. So before going on to the presentation, let me briefly tell you guys about today's presentation. So in this presentation, I will be discussing the basics of merit-based incentive program system, alternate payment model. I will be basically discussing bit about the eligibility, like which physician and doctors are eligible to participate in these programs. I will be also discussing the financial impact, that how these programs will be impacting your bottom line. And at the end of the presentation, I will be briefly discussing all these MIPS categories. In the next webinar, that is on 31st May, we will be going through in details with all those stories and measures. So MACRA, it's Medicaid Access and Authorization Act, which has been signed as a law back in April 16, 2015, and once it has been passed by Congress, Health and Human Services and CMS start working, and they came up with the final draft on October 14, 2016. So that's basically the law through which Quality Payment Program, or QPP, emerges. And we're going to discuss what QPP is. The reason for Quality Payment Program is to promote quality over volume. As you guys are quite familiar, you have been following fee-for-service schedule from last 2 decades. So CMS is now thinking to switch that from volume-based towards value-based. So that is the basic foundation of Quality Payment Program. It obviously gonna end sustainable growth formula. These reforms will be impacting around like 600,000 clinicians. Obviously, it will improve care across entire healthcare delivery system, where physicians, primary care physician and specialists can coordinate in a way that will help to give good services to the patient and obviously save the cost as well. Before going further into the presentation, let me try to connect the dots in the past as well. As you guys may be familiar of the programs called PQRS, Physician Quality Reporting System, Value-Based Modifier, and Medicare EHR Incentive Program. Quality payment programs are basically the consolidation of all these 3 programs which doctors were participating till 2016. So Quality Payment Program also divides further into Merit-Based Incentive Program system. Basically, there are 2 tracks for Quality Payment Program. One is MIPS, Merit-Based Incentive Payment System. The other one is Alternate Payment Model. So as a doctor or as a clinician, you will be eligible to participate in one of them. It's not possible for any physician or doctor to go ahead and participate in both of these tracks of quality payment program. And later slide we will discuss the eligibility part as well. Okay, quality payment program has two tracks. So merit-based incentive payment system is for those physicians and the doctors who see traditional Medicare Part B patients. So it means those physicians who have Part B patient volume are more likely to participate in MIPS. Advanced alternate payment model, those physicians who are already part of some innovative payment model, for example, MIPS and ACO, CPC, and other innovative payment programs, so they have to participate through those programs. So before going further into the details of MIPS, let's briefly touch on advanced alternate payment model. APMs is payment approach that gives added incentive payments to those providers who are part of population management programs like CPC, Next Generation ACO model, shared saving program with track 1, track 3, and also OCM. So these are basically the population management program. If as a physician you are part of one of these programs, then you are not eligible to participate under merit-based incentive payment system. Then you will be obviously going for the advanced alternate payment model or APM. So if you go ahead and participate under advanced APM, the physician will be getting an incentive of up to 5%. The basic criteria of eligibility under APM is like if you see 20% of your Medicare patients through advanced APM, then you can go ahead and apply for this incentive, or 25% of your Medicare patient payment, or you receive your 25% payment through Medicare, then you can go ahead and participate under APM. So now let's discuss the merit-based incentive payment system, which is also called MIPS. As I told you earlier that basically MIPS is consolidation of these three programs, PQRS, VBM, and Medicare EHR incentive payment system. What is MIPS? Basically, MIPS is the consolidation of all those three programs, and now they are coming up under 4 new domains. So you can say MIPS is basically the combination of these 4 domains. That is number 1, quality, which replaces the old program PQRS. There is new category of improvement activity. Then advanced care information is the 3rd category of MIPS, which is EHR incentive program, which most of you have been aware of all those core and manual measures. And then at the last we have cost. Cost replaces the old program called value-based modifier as well. So that is basically episode-based payments comes under cost. So as a physician, if you want to go ahead and participate under MIPS, so you have to perform on all 4 categories of MIPS. It's not like you pick and choose. You say like, okay, I want to go ahead and submit quality or advanced care information. I want to skip clinical improvement activities or source use. No, you have to participate in 4 of the domains to get the maximum score in order to get the incentive. So it's not about like saving yourself from penalties. It's also about incentive as well. So as much as scores you get, which we say is like MIPS composite performance score, which we will be discussing how a doctor can get maximum CPS in order to avoid himself or herself from penalties and also gain a handful incentive as well. So basically MIPS is the combination of all these 4 domains or categories. Okay, These domains and or the categories have some percentage or number to be calculated so that end of the year every doctor will be coming up with their CPS score depending on the participation on these programs. So quality domain has 60% of weightage. So this is one of the main and important domain which basically drives from Physician Quality Reporting System or PQRS in the past. Cost, remember 2017 is a transition year. So in this year, CMS gave a leverage that they are not expecting any percentage or participation in cost category, but after 2 years, there will be a 10% weightage to cost as well. So it has some 40 odd more years depending on the episode of the visit. So they have 40 odd measures. So for this year, there's nothing to worry about cost. Then comes improvement activities. It holds 15% of weightage. There are like 92 odd activities which out of which doctor needs to perform for 3 to 4, which we will be discussed on later as well. Advanced care information holds 25% weightage, which is whole meaningful use. So you can see over here these 4 program consolidation, and at the end of the day, your scores will depict how much incentive you will earn, or you can save yourself some plenty as well. Okay, very important question, who is eligible? Because 2017 is the first year of all these programs, so there are a lot of doctors who are confused. Some are saying we are not eligible, some are saying we are eligible. So let's briefly go through the eligibility criteria for MIPS. Physicians, physician assistants, nurse practitioners are eligible to participate in MIPS 2017 for first year and the second year. But from third years onward, there will be another, like healthcare provider will be added as well. So for the first 2 years, it's all about physicians, PAs and NPs, and physician has been explained as doctor of medicine, doctor of dental surgery, doctor of dental medicine. So all these doctors needs to participate in MIPS in order to avoid 4% penalty, which we will be discussing later in the presentation. So CMS used the word eligible clinician or eligible clinician. So as in the past, in the PQRS or the meaningful use, we used to use a term called eligible professional, but in MIPS, it's eligible clinician. So if you are one of the physician or PA or NPs, so you should better prepare yourself to participate in MIPS in order to save 4% penalty. Okay, then who is excluded from MIPS? If as a physician you are enrolled with Medicare Part B in 2017, right, you're gonna get an automatic exclusion from MIPS. You are excluded from Merit-Based Incentive Payment System. Or if you have less than or equal to 30,000 collection from Medicare Part B patients in any of the past years, specifically in 2016, then you can still go ahead and apply an exclusion, or you will be getting an exclusion, right? Or if you see less than 100 Medicare Part B patients, you still go ahead and gonna get the exclusion. And the third one, automatically, if you are part of any advanced alternate payment model, you cannot participate in MIPS. You're gonna get an automatic exclusion in that as well. Okay. CMS also provide very interactive eligibility tools as well. You can go to the website called qpp.cms.gov. On the first page, you just need to put your individual NPI, and once you're gonna put your NPI, here's this sort of a result card gonna come out. So CMS interactive tool gonna tell you, okay, you are eligible for participation in MIPS or not. So if you can go through and check those 2 to 3 criteria, if not, then you can go to that website and then you can just put your individual NPI in that, and CMS website will be telling you, okay, you have to participate in MIPS or you're eligible to participate in MIPS or not. So that is really a helpful tool to go along and check your doctors or your own eligibility for MIPS. Okay, now I will be discussing MIPS timeline. 2017 is a reporting year or the participating year in which you have to perform certain or you have to collect measures, data for certain measures, right? So that is your performance year or the reporting year, right? So you will be collecting the data in 2017 and you need to submit that data to CMS from January 1st, 2018 till 31st March. So the reporting period or the performance period or the performance year is 2017. A data submission will be done in the first quarter of 2018 for 2017, and the impact or reimbursement will be coming up in 2019 on the basis of 2017 participation. So it's really clear, like if a doctor do not do MIPS in 2017, doctor will face a 4% penalty in Medicare from Medicare in 2019. And if you go ahead and participate in 2018, then you will get an incentive, or if you are not complying with the CMS criteria, you will be facing a penalty in 2020. So there is always a gap of 1 year for the financial impact coming to your practice. Okay, that's very important. MIPS incentive payment formula. For 2017, 4% is the penalty for those doctors, or we call it negative adjustment, for those clinicians who are eligible to participate in MIPS, but they don't submit any data, right? So there will be a 4% penalty in 2019 on the basis of non-compliance in 2017. Okay. On the other side, if you comply with the criteria, the basic criteria for this year, you might get 4% incentive as well. So it's all about saving yourself from 4% penalty or negative adjustment and getting 4% incentive. So that's the basic criteria for penalties and adjustment. On top of it, which is really important and most of the doctors get confused, there is $500 million for the top performers, right? So if, for example, from 100, which we already explained you, for quality have 60% weightage, then improvement activities have 15% weightage, and advanced care information has 25. So it's total of 100 as your performance score. So if a clinician go ahead and score 0 out of 100, right, that clinician will be facing a 4% penalty in 2019. There is another clinician who scored around like 3 to 4 out of 100, right? That clinician will be safe from 4% penalty. So it's like if you report anything, you go ahead and save yourself from 4% penalty, right? But if you don't report anything, you will be subject to a 4% penalty. If you put a bit more hard work this year, if you select a bit more measures, which we'll be discussing in our later session, the measure section and the scoring methodology as well. But if you score from 3 to 69 out of 100, then you might get incentive, or you're gonna get that 4% incentive. So it's like 0 out of 100, physician will be facing penalty, right? And if you score anything, either could be 1 by 100 or 2 by 100, you will be saving yourself from 4% penalty. And if you score from 3 to 69, you might get 4% incentive as well. So you see, as you put a bit more in these programs, it can impact your financial bottom. And the most interesting part, if you score 70 equal to 70 or more than 70 out of 100, you will get a chunk out of this $500 billion as well, which starts from 0.5% and it goes up to 10%. So let me just explain it with an example. For example, there is a physician who have a Medicare collection of $100,000 annual, right? So if that doctor scores around 75 out of 100, the doctor will be saving himself from 4% penalty, right? On top of it, doctor will get 4% incentive, which is the basic incentive under MIPS, and on top of it will more likely will be getting 10% chunk from that $500 million. So you see, there is an impact or increase in your reimbursement up to 14%. So that's very important as a physician for you to, decide on the right measures and right reporting period, because if you expand your reporting period of these measures, it's gonna increase your chances of getting max incentive out of this 500 million top performer incentive. So, okay, let's have MIPS in 2017, MIPS at 4% up and downward adjustment, right? Either you can get 4% incentive, or you can get penalty, or you can save yourself some penalty and also get incentive. In 2018, the impact is 5%, right? And in next year, it's going to increase by 1%. And under QP advanced APM, it's 5% bonus. And obviously, those doctors who are participating at the MIPS cannot apply under APM. So I did rough estimation of that. So usually MIPS is known to be a budget neutral program. CMS expecting 50% of the doctors to perform or to get an incentive, and 50% of doctors to, perform below par. So as per their estimation, it's 83 million could be the adjustments, and same goes at 33 million as a positive adjustment for those doctors who perform well, and also $500 million add up to those doctors who perform very well under MIPS. So it's going to maximize their reimbursement. Okay. Now I will be going through the basics of 4 domains, basically the categories of MIPS, or what a doctor needs to be done to get the maximum score in order to secure the maximum incentive. Obviously, in the next session, I will be going through more details of scoring and I will be sharing more details so a doctor can maximize the incentive by selecting right measures and reporting period. But from now onward in this presentation, I will be explaining the basics of all these 4 categories in order to give you guys more understanding of these categories. So quality is measure-based category or domain. If you remember the measures in physician quality reporting system, cancer screenings, yes, I'm noting down the BMI, these sort of measures are part of quality payment category. Okay, MIPS quality performance category, total 271 measures in it. Key changes from PQF, in the last year, a doctor needs to select at least 9 measures from 3 different domains, but this year under quality domain, there is no story and there is no domain or category system within the quality program. The doctor just needs to report 6 measures in order to get the maximum weightage, that is 60% in this domain. Although you can go ahead and still report 1 measure and you can get some score in order to save yourself from the penalty, but then I'm talking about selecting at least 6 measures depending on your specialization. It's mean to get the maximum score increase your chances to get the max incentive, right? So that's the basic criteria, just selecting 6 measures as per your specialization and report those measures on 50% of your patient population for the whole year. Not only Medicare Part B, all insurances. So let me just give an example to elaborate this. Okay. For example, a physician sees 100 patients in a year, right? That includes all insurances, Medicare, commercial BCBS, Aetna, and all those commercial insurances. So a doctor should collect these 6 measures data for 50 patients out of those 100 to get the max score in this category. So if you remember in the past, sometimes you guys, if you participate to registry for PQS, you just collect 20 patients data for one whole measure group, or you can do it for 50% of your Medicare patients if you are reporting through claim. But this year, it's 6 measures, and that should be for 50% of your total patient population for that particular reporting period. And emphasis on outcome. So if you go ahead and select 6 measures, try to select outcome measure at least one, so it's gonna increase your scoring as well. We will discuss this in our next session, the combination of measure, and we will recommend some combination of measure for different specializations as well in that session. So this category have a weight of 60%. No, the second category, that is resource use. So for this year, it's like care, episode, and clinic condition group. Resource group, there are basically 40 plus episode specific measures which CMS already has introduced. But the best part is that for 2017, nothing to worry about like this category. So we're gonna be discussing this in like later years, so a doctor can get the maximum score once there will be a score for this category. Okay. The third one is improvement activities. Example include care coordination, shared decision, safety checklist, expanding practice success. So basically, this domain or this category is a combination of 91 activities. So, for example, there is a measure you give your patient 24/7 access to their patient record. So that particular measure can be met through a patient portal. If you have patient portal, and if you have your patient have an access to that, and you go ahead and meet that particular criteria. So in order to get the maximum score for this category, a doctor should at least select 4 measures or activities to get 15% max score in this category. If you are already part of PCMH, patient-centric medical home, you're gonna get full credit for this category and half credit for APM participation as well. So there are some measures exist overlap between APM and improvement activity. So in case you do that, you're gonna get the half weightage in this category as well. So 15% is a total weightage for year 1 for this category. Okay, no MIPS advanced care information, the 4th category. That's very important. You may be aware of all those core and menu measures like e-prescription, CPIAs, like giving patient electronic access. And if you remember, there is a percentage threshold. For example, you should need like give e-prescription to 50% of your patients. So they were like numerator and denominator in the past. But no, there is no numerator and denominator. You have to just like perform certain, all those things which you were doing in the past for the 15 measures. The CMS have, you know, sum up 15 measures out of all those measures, core and menu measures, right? And they gave the weightage to them. For example, ERX have 5 numbers. So if you do ERX, regardless of how many patients have, how many thresholds, you are meeting, but still if you are going ahead and doing ERS, you're going to get 5%. But the maximum scoring is with those measures of public health or interoperability. For example, immunization, syndrome surveillance, or syndrome registry, or you send the data to different registries. So public health measures and interoperability measures, HIE measures. For example, you give maximum of your patient to access patient portal, you use secure messaging for out referral, you do medication reconciliation. So all these measures have much more score or some bonus scores as well. So the basic, the demographics or the smoking status, all these measures have, low score as compared to HIE, interoperability, or public health measures. No performance threshold, high score, bonuses score for public health and interoperability measures. So here is basically the summary, right? In quality, if you achieve 70 to 80 points, right? 60% is the total scoring, but the number is 70 to 80. If you get 80 points, you're gonna get the maximum score of 60 in quality. Same goes for advanced care information. In advanced care information, if you score 100 points, then you will be getting the maximum cumulative score of 25. And in improvement activities, if you go ahead and report 4 measures or 4 activities, you will be getting the maximum score, that is 40%. So this is how their scoring is. And even in like advanced care information, meaningful use, if you go ahead and submit 5 measures, you will be getting 60-odd score. And if you go ahead and submit 9 measures, include immunization and patient portal measures, you will be getting maximum score of 25. So this is how the scoring or your composite score will be calculated. The later session obviously will be discussing measures, the combination, and like also we will be recommending some measures to certain specialization, because these measure selections are as per your specialization and your scope of practice as well. So that they may be various specialization to specialization. Okay, that's very important. Like on internet or CMS, you're gonna heard all about incentives and penalties and reimbursements and everything. But there is another catch, which is other than incentive or penalties. CMS already prepared a website called Physician Compare website. So whatever score you're gonna get in 2017 and MIPS, right, that will be publicly reported on this website. And this website will rate doctors out of 10 on quality or coordination, basically on all those measures. And basically it's a sort of, defining or a good doctor or satisfactory doctor, or the doctor who provides good services, or the doctor who provides satisfactory service. So that's very important. If you are like not convinced to participate in these programs because of incentives and penalties, then this is much bigger than the, those incentives and penalties. So these are the references. They are the main websites you guys can use to get more information on these programs. And our next webinar is scheduled on 31st of May. You can go ahead and register yourself in that, and that's gonna be really specific. We are using this session as to just give the basic or the introduction of these programs. But in the next session, we will be discussing hardcore measure selection criteria, reporting period as well, and reporting mechanism as well. So you guys can still register yourself for the next webinar. And if you have any questions, you can go ahead and just like send us an email or give us a call. Or Emily, you there?
Yes, I'm here.
So it's over to Emily in regards to questions. So if you can just go through some questions so that I can go ahead and answer those.
Okay, we have a few questions from the audience. They are asking if I see most of my patients in the hospital and I bill under POS 22, I still need to do MIPS?
Yes, that's a very interesting question. Like most of hospital physicians are a bit confused, like these programs are for the outpatient, but yes, place of service 22 or hospital physicians should participate in MIPS. The best part for them is that they will be getting an automatic exclusion and advanced care information or the meaningful use category. So that's the best part, but still they need to participate in that.
Okay. And if there are any other questions, we won't be able to go over all of them, but you guys can go ahead and email us at info@SybridMD.com. There's another one where one of them are asking, when will I get incentive of 2017 MIPS?
Okay, as I mentioned, 2017 is the participating or the reporting year, and the reimbursement for this particular year will be in 2019. So you will be getting that in 2019.
Alrighty. Let's see. Okay, there's this one. I don't see Medicare Part B patients. So this is one of the doctor who is asking. I don't see Medicare Part B patients. Am I eligible for MIPS participation?
Okay, if you don't see Medicare Part B patients, you will be getting an automatic exclusion. So there is no need to participate this year if you don't see any Medicare Part B patients.
Alrighty. Any other questions? If anyone has, please let us know.
Okay,
so
I can see. Okay, go ahead.
Yeah. So Sabrina, she's asking, we are a specialist office, so we do not do primary immunization. How does it affect my measures?
Okay, good question, Sabrina. If like a lot of doctors don't do immunization, so if you don't do immunization, and you don't report immunization measure, it does not stop you from getting the max number in advanced care information category. You can still get an exclusion in this measure. You can select on any other measure which is applicable to your practice, right? So it's not the only measure you're gonna be thinking about. So if you exclude your practice from this measure, you're gonna still get 25% of the max score in advanced care information.
Alrighty. How is it different for hospital-based physicians like hospitalist?
Okay, again, for hospitalists, yes, they need to participate in MIPS. So it's mandatory for them, or it's like if they want to save themselves from penalty, they need to participate in MIPS, right? But there is a slight change in that. If you are aware of meaningful use program, right? So there is an advanced care information category for this year under MIPS. You guys cannot get an automatic exclusion in that category, but rest categories still remain the same for you. That is quality and improvement activity. So you need to score maximum out in these two domains, and for advanced care information, you will be getting an automatic 25% of max score in that. So it's a bit easy as compared to outpatient physicians.
Alrighty, and then we have Tammy. When you see patients in the hospital, how do we code for those to be in compliance?
For this question, our next session will be very important, but still I can briefly answer this question. Basically, it's all about selecting some measures, and you have to report certain measures are performed. For example, I can pick an example, generic, and it might be oncologists or anything like that, cancer screening or cancer screening, right? So, for example, there's a measure called you have to do cancer screening for your patients. Like, so for those patients who have diagnosis of cancer or they are Medicare patients, you can just ask them, okay, did you perform cancer screening? They're gonna say yes or no. You can just document that or you can recommend them. So I'm just giving you a generic example, but in the next session we will be going through some practical measures. So there is like a formal language used for documenting the records, but still these measures goes like this. So in hospital, you have to select measures as per specializations, and then you have to collect the data for the whole year or for the 90 days depending on your target, like if you want to get the basic incentive or max incentive, and then you can go ahead and report that to CMS.
All right. Let's see. Will HECFA affect MIPS or MACRA?
No, not really. It
I'm
does
sorry.
not impact the ACOs or sorry, to MACRA or MIPS. It's a separate program. It does not give you any leverage, or the bill does not impact the MACRA or MIPS. So that is something which is totally focusing on basically the question in regards to Donald Trump's recent changes in Obama healthcare reform. So ACA basically impact the patient side, right? As in Obama healthcare reform, they were like to give like 2 million patients the insurance. So that impacts the patient side, the deductible or the premium. That does not impact the clinician or the vendors EMR side. So that is different. So that won't be impacting till date. That does not affect MACRA or specifically MIPS or APM.
Okay. Let's see. Where are the measures we should be choosing from?
Okay, in next session, we will be explaining that as well. And I just note down, you can go to the website qpp.cms.gov. All those measure specifications are there. And after the webinar, we will shoot an email to you as well to provide a link for all those measures as well.
Alrighty. Let's see. Sylvia, yes, we can print the PowerPoint presentation. And there's one more. Just give me a sec. I think you already answered this one. Yeah, that's about it. And there's another one, which is the A8CA is the new healthcare bill from GOP. I think they're asking a question.
I answered that question. It's like, again, it does not impact the MACRA MIPS.
Okay, and then how is Sybrid supporting MIPS data submission?
Sybrid basically, this is like our first effort to tell you guys the basic about the MACRA, and we will go ahead and also provide more education on these programs. and we're gonna see response from your side. If you guys are more interested in some customized sort of service as well, we will be more than happy to assist you and ensure that you get the max incentive. So this is the first step towards that. With the passage of time and depending on the response, we might go ahead and provide some customized service or consultation in regards to MICRA, where we will ensure your 100% compliance with these programs.
Alrighty. Well, I think that's all.
Okay.
Yeah, and if you guys have any other questions, again, do email us at info@SybridMD.com. And again, the next session, you said it was on May 31st, and the invite will be going out.
Okay, thank you so much, everyone.
Thank you. Thank you, everyone, for joining.